Good evening, ladies and gentlemen. It's an honor and a privilege to be here tonight. When I was asked by the conference organizers to speak to this august gathering, I replied that I would like to know more about the attendees, such as whether they could be broken down by sex and age. Looking out at this crowd, I see that's already happened to most of you. Indeed, this group reminds me of a famous Broadway play, Death Takes a Holiday. Those were the words of the late great C. Walt Lillehei at the retirement party for Christian Barnard circa 1887, which was the same year as the first maze procedure performed, of course, by Dr. James Cox. At the time, I was a research fellow for the great, always late but worth the wait, Bud Frazier, whom I saw at our last meeting. I said, "You're looking good, Dr. Frazier," at which point he informed me you have 3 stages in your life: your youth, your maturity, and you're looking good. But seriously, folks, I stand before you not as a legend or any sort of expert, despite all of Danny's kind words. I'm a simple, solo private practitioner who was inspired by the presidential lecture of Dr. Bob Guyton at the SDS about 20 years ago. He challenged us to learn at least one new procedure every year. So I took it upon myself to learn the maze procedure, specifically the Cox Maze 4. And I learned it from the man who worked directly with Dr. Cox, namely Ralph Damiano, and also from a man who has become a dear friend of mine, who happens to be in the audience with us tonight, for Sidney Gaynor. Thank you, Sid. And I would tell you, if you get a chance to talk to him, he's a truly unique individual. He has trained more surgeons in more countries than I bet any of you in this room can name. Go ahead and try him out. Subsequently, I integrated the maze into some form or fashion in any operation, including left atrial appendage closure, in every patient that I had with atrial fibrillation. And again, this was 20 years ago that I started doing it. I found very quickly that the patients restored to sinus rhythm after years of atrial fibrillation were exceedingly grateful. I remember a lady who was a nurse, been at AFib for 25 years, and afterwards, when she was in sinus rhythm, she said she hadn't felt that good in a millennium. And as you see, I'm not the only one who thinks like that. Roughly 10.5 million people in the United States have AFib, 52 million worldwide. Some 30% of cardiac surgery patients have pre-op AFib, either chronic or previously documented. Overall, 30 to 70% of patients undergo surgical AF ablation and or left atrial exclusion. So it really depends on what operation they're having. You all know about macro reentrant phenomena as the cause of atrial fibrillation, and most of you probably already know the maze surgery. And hopefully you all know that the maze procedure over time does confer serious benefit in terms of freedom from atrial tachyarrhythmias. And I'd also like to believe you're all fairly familiar with what's happening when we say amputation of the left atrial appendage. Multiple ways to do it. More recently, amputation of suture has been largely supplanted by these epicardial devices, of course. And there have been several very nicely done studies with enormous patient populations showing that indeed, if you do perform left atrial exclusion in some form or another, that you do confer freedom from both stroke and other arterial embolization. It's interesting, in this particular analysis, which just 5 years ago, over half the patients had amputation and suture, but in recent years, of course, ECLIPSE have largely eclipsed that. But what's disconcerting, and I say this not just to the surgeons, but to the cardiologists, because you're all the ones who refer these patients to the surgeon. You know, the surgeons are always trying to please you. They don't want to argue with you. But nevertheless, in 20 years of doing the maze procedure, I still find myself asking people, don't you want me to do the maze procedure? It's vastly underutilized because although in mitral surgery, it's almost 72%. As you go down this list, you'll see in isolated CAB, it comes down to about 31%. It's very, very low. I would also like to point out, Laura, where's new Dawn Huey? Somewhere around here.
There's nothing left?
Dawn, where are you? Oh, she's right over here. Notice here in this list of authors from this expert consensus report in 2023, so just 3 years ago, clinical practice guideline is a class 1 recommendation. Atrial fibrillation should be treated in some form or fashion at the time of cardiac surgery. So I'm hoping now that Don has joined us over here at UT Memorial City, we'll have some new impetus towards more cardiac surgery for atrial fibrillation. This slide, of course, is impossibly busy, but I have to show it to you because it's a fascinating example of how culture changes. Because if you start at the beginning of the slide, like I said, 1987, 40 years ago, really, next year. Sid, I hope you guys are planning a 40th anniversary party. 40 years ago, there were no guidelines. This was some crazy idea that Dr. Cox had come up with. But if you read his upcoming book, which I understand has already sold out the first 1,000 copies, and I'm very mad because I was promised one from my friend here, and he didn't deliver. I'm going to hold out and see what happens. 40 years ago, people were thinking this was, some sort of voodoo, juju, black magic, whatever, maze procedure. But it's not. It's science. It's, in fact, one of the most scientifically derived operations that we have in all of medicine. And over the course of the last 40 years, you can see that the class of recommendation and the level of evidence has steadily risen. And if this were a stock, I guarantee you'd be buying it. Because all these societies, Society of Thoracic Surgeons, American College of Cardiology, American Heart Association, European Society of Cardiology, Heart Rhythm Society, they've all slowly but surely, inexorably recommended surgical treatment of atrial fibrillation in patients going to the OR. So I just want you to very simply go home tonight and think about what you heard here, both the brilliant presentations we heard earlier and my simple one. AFib, only cold steel can heal. I know we've got a lot of electrophysiology people here, but the full Cox-Maze-4 remains the gold standard. And also to maybe pique your interest in the future, I want you to think about this idea that fibrosis begets fibrosis. And what do I mean by that? When patients have atrial fibrillation and they get a dilated atrium, of course, as the cardiac myocytes slowly separate, nature abhors a vacuum and something has to go in there, and that something is fibrosis. And fibrosis increases resistance to electrical conduction, and therefore you have more atrial fibrillation. So it's a fascinating area, epicardial adipose tissue and associated inflammation, that could potentially be able to predict patients who will develop AFib using AI-enhanced CT imaging. That's the image you see with the nice yellow, green, and red. There's also now, of course, AI analysis of EKG, which could potentially predict future atrial fibrillation. And lastly, although the study only recently came out, it was only done in pigs. As you know, pig hearts are fairly similar to human ones, and the use of epicardial drug delivery with various patches has been shown with amiodarone and I'm sure other drugs in the future to reduce atrial fibrillation. So it's something to think about, and I sure do appreciate your attention. Thank you very much.